All righty. So let's just jump straight in to number one. We have a patient that is seen for hypertension. Her provider has her on prescriptions, but her blood pressure is not yet at goal. Patient does not exhibit any symptoms. So when we are referring to the number and complexity of problems that are addressed, so in that MDM table, what type of problem is this going to be considered? So from an MDM leveling for number and complexity of problems addressed, what type of problem is hypertension? She's on prescriptions, but her blood pressure is not at goal. So we've got stable chronic illness with an exacerbation, progression, or side effects of treatment, chronic illness with a severe exacerbation, progression, or side effect of treatment, and then an acute or chronic illness or injury that poses a threat to life or bodily function. Okay. So Caressa says B, it's a chronic illness with exacerbation, progression, or side effect. Okay. Anybody think anything different? Everybody agree on B? Okay. Dawn says it's a stable chronic illness. Jeannie says stable chronic illness. Okay. So the question begs, even though they're not exhibiting any symptoms, right? If her blood pressure is not goal, this is the key sentence here, or the key phrase. So the key phrase in this is blood pressure is not yet at goal. That is going to not be stable because our numbers are not where they need to be. If that makes sense. It's not necessarily an acute or chronic illness that poses a threat to life or bodily function. And then it's not a severe exacerbation because they're not saying that the blood pressure is severely elevated or blood pressure readings, are on the high level of like stroke, protocol or anything along those lines. So it's going to be a chronic condition with exacerbation, progression, or side effect of treatment. Okay. Does that make sense to everybody? Any questions on that? So again, that's the key piece of information is the fact that blood pressure is not at goal. So we cannot consider it stable if their blood pressure is not where it should be. Okay. Any questions? Okay. Number two, we have a 32-year-old patient that sees Dr. Smith for a consult at the request of his primary care provider, Dr. Long, for an ongoing problem with allergies. The patient has failed Claritin and Alavert, and he feels that symptoms continue to worsen. Dr. Smith performs a medically appropriate history and exam and then discusses options with the patient on allergy management. The patient agrees that he would like to be tested to possibly gain better control of his allergies. And Dr. Smith sends a report to Dr. Long thanking him for the referral and includes the date that the patient is scheduled for allergy testing. Dr. Smith also includes his findings from the encounter. So, with this one, before we even look at our codes, right? What type of office visit or what type of service is this? Is this an office or other outpatient service, or is this going to be considered a consultation? Does everybody remember the three R's for a consultation?
Request, render,
Mhm.
and report.
Yep. Yep. So we have the request, right? The request of at the request of the primary care provider. They have rendered their service. So they perform the medically appropriate history and exam and they discuss. So there's our second R for rendering. And then they've done a written report back with their findings. So he sends the report, includes the date, and also gives the findings of the encounter. So we know at this point we have a consultation, right? So we can get rid of A and B because these are office or other outpatient services. Okay. So now if we go look at 99242 and 99243, we just have to figure out what the difference is. And then we've got to level it and figure out what level of service we have. So the difference between our 99242 and 99243 is one is straightforward and one is low. Okay. So if we level out our MDM, let's go to our MDM table. The first thing that we have to do is figure out the number and complexity of problems that are addressed at the encounter. So I'm just going to come down here and I'm going to say number and complexity of problems. Okay. So what is our problem? I'm going to take away these highlights. What is our condition that is being addressed at this consultation? Yep, it's our allergies, right? Okay. So for our allergy, what level of number and complexity of problems addressed are we going to fall under? So allergies, is that going to be considered an acute or a chronic condition? Okay. Normally it is. However, because they have attempted Claritin and Alavert and they have failed and his symptoms are continuing to worsen, that makes it a chronic condition. Okay. So now is our chronic condition, is it stable or is it exacerbated? Okay. Yep. It is not stable. Right. Because they have failed the Claritin and they're continuing to worsen. So that's going to be a progression or an exacerbation, right? So knowing that we have a chronic condition with progression, what is our level for the number and complexity of problems that are addressed? Yep, it's going to be moderate. Okay. Does everybody see that? Okay. So now we need to do the amount and complexity of data. Okay. So the amount and complexity of data. This is where we have to consider any external notes, reviewing the results of any unique test, or ordering of any unique tests, as well as independent historians, and then discussion of management or test interpretation. So, did we review any tests that were done previously? So, we didn't review any previous tests, but we ordered a test, right? Right. So, we ordered a test. And so they agreed that they want to be tested for allergies to figure out what it is that they're allergic to gain better control. So that's not a review of a test, that's an ordering of a test. So if we order a test, we cannot also count the review of that test. Okay. So the review of the test is going to be inherent in the ordering of the test. Okay. Does that part make sense? So we have ordered one test. So what level of medical decision making, not medical decision making, sorry, what level of amount and complexity of data do we have if we ordered a single test? Okay. Okay. So I've got a couple that say low. In order to have a low amount and complexity of data, then it says that you have to have two in your category one. We only have one, right? So we only have 1 point in the amount complex, or I'm sorry, in category one. So we don't have enough for a low. So if we have 1 point, we're going to be considered minimal. Does that make sense?
So one test will put you in the minimal category.
Yep. If we have two tests, then it's going to be a limited. And then three tests would put us at a moderate. Yep. Because remember, if you look at your um it's your column for amount and complexity of data, then underneath limited, it says that they have to meet at least one of the two categories. And then for category one, it says any combination of two from the following: the review of prior external notes, the results of each unique test, or the ordering of each unique test. So you have to have two of those that are met in order for the low to be met. Does that make sense?
Yes, yes.
Okay. I know this is almost the hardest part of them is figuring out each individual level. Okay. So if we have a minimal amount and complexity of data because we have one test that's ordered, that gives us minimal. Okay. So now we're going to go to risk of complications. So our risk of complications is going to be based on what we are doing and the treatment options. What are the risks of something happening? So, with the allergy testing, what would the risk of something happening with that allergy testing What are the risks of a complication arising? So remember, our minimal risk of complications are going to be things that you can do at home. Rest, gargle, ice, heat, elevate, things along those lines. The low risk is going to be over the counter medications, minor surgery without any risk factors, physical therapy, occupational therapy, IV fluids. So we're taking a little bit of like a risk, right? It's not, we're just going to go home and rest. We're not going to go home and do ice and heat, but it's increased a little bit. We're still not doing a whole lot of medical intervention. We're not doing prescription drugs. We're not doing any type of major surgeries and things along those lines. So the risk of complications of allergy testing is going to be low. Okay. Does everybody see that? The low risk of complications for allergy testing. Okay. Any questions on that one? So now that we have moderate number and complexity of problems, minimal amount and complexity of data, and then your risk of complications is low, what is our overall MDM? Okay. Moderate number and complexity of problems. You only have to have two of the three elements in order to level our MDM. So moderate, minimal, and low. Which row do we now have two elements in? Okay, yep. So Xenia says low. So it's a low medical decision making. Does everybody see that? Any questions? I know MDM can be tricky on low. Let me pull up something here real quick. And I'll show you guys a little bit easier way to figure out your level. So if you have each of your um, components here, right? We have a moderate number and complexity of problems. We have a minimal amount and complexity of data. And then we have a low risk of complications. We technically don't have a column that has two components, right? But if we've met moderate, we have met and exceeded low and minimal. If we've met low, we have met and exceeded minimal. So now we do have a column with two components. So that's why our overall MDM is going to be the low medical decision making. That kind of helps seeing it in this aspect. So if we have a low medical decision making, then our consultation is going to be a 99243. Okay. Any questions? No, go ahead.
So Tiffany, there's nothing with timing with this then, right? You
Right.
want,
Right.
okay.
Yep.
Okay.
In this instance, we're not basing our level on the time component because they're not
Okay.
telling us how much time was spent
Fine.
with the patient. So
If
if
they
they
were,
don't give us, then we're only going to go based on the leveling of the MDM.
but if they were, do we would do both or just
Well, it
over?
depends.
Oh,
It
okay.
depends because you're going to go with whatever's going to give you the highest level. So if they
Okay.
told you that we only spent 25 minutes, that's going to
Mm-hmm.
only support a straightforward, right? That's only going to support the
Mm-hmm.
942.
Right.
But if our medical decision making supports a higher level, then we're going
Mm-hmm.
to go with the higher level.
Okay.
Yeah. So you don't want to just only do time
Okay.
or only do MDM. If they give you both,
Mm-hmm.
then you just need to determine which one is going to support the highest level so that we
Mm-hmm.
can make sure that the provider is getting paid for either their time or the medical decision making. Yep.
Okay. Okay.
Yep.
Makes sense.
Okay.
Thank you.
Good question. You're welcome. Okay. Any other questions on that one? Okay. Let's do number 3. Dr. Howitzer sees Mrs. Jones in Clinic 8 for sudden loss of consciousness while watching the Olympic torch go by. He is a new provider to the neurology department, and Dr. Drake Rinaldi, a prominent member of the neurology faculty at the university, saw Mrs. Jones last month. Dr. Howitzer performs a medically appropriate history and exam. Medical decision making is of high complexity. The final diagnosis given is transient loss of consciousness, and the patient makes a follow up appointment to see Dr. Rinaldi in 1 week. So for this one, you see that you have some codes that are established patient and some codes that are new patient. For this scenario, are we a new patient or are we an established patient? Okay, so Jeannie says established. Okay, what makes it established? So it's the first time that that this patient has seen Dr. Howitzer, right? Because they're a new provider to the neurology. So I'm just, and what's making it, in your guys' opinion, an established patient?
Because it's the same, it's the neurology department, and she
Mhm.
usually sees one doctor, but now she's seen a new doctor
Yep. Yep.
to the
So since
practice.
she has been seen by a neurologist within the same practice, exactly. Yep. Then they are established with the specialty. Yep. So it's not necessarily a matter of that specific provider. It's a matter of practice and specialty. Yep. Perfect. Good. Okay. So we're going to be able to rule out the new patient, right? And then let's say you're in testing and you're like, my brain is done, my brain is shot. I am not going to sit there and level if I don't have to, right? So we figured out very quickly that it's an established patient and we know that we're down to 2. So now let's look at the diagnosis codes and figure out which one it is that we need to code. So what is our definitive diagnosis?
Transient loss of consciousness.
Yep. Yep. The transient loss of consciousness. Okay. So now we just got to figure out, is transient loss of consciousness going to be the R40.1 or the R55? And then let me know when you guys look which one you think we should use. So R40.1 or R55? Yep. Yep. So we're going to use R55. Even though it doesn't include transient loss of consciousness, it does include blackout, fainting, vasovagal attack. So we know that those are going to be examples of loss of consciousness. Okay. So this one, we didn't even really have to truly level anything. We just had to figure out new versus established and then figure out our ICD-10 code. Okay. Any questions on that one?
Can I use, it says making high complexity, so medical decision. So can
You
I?
could. Yeah.
Okay, thank you.
Yeah. You could have gone and done that. For sure. Okay.
Thank you.
You're welcome. All right. Number 4. So we have a soccer
Hi,
player.
Tiffany.
Oh, go ahead.
Been like I've been sitting here struggling for the longest, so it just popped me in for somehow. Um, so I'm gonna like just fall back because I don't know where you really at. I kind of tried to tag you earlier just to see what we are going to be discussing this study group.
Yeah. Yeah. No, that's totally fine. I know Zoom has its own mind, but we are recording it, so it'll be available whenever we're done. So that way you can catch up, for the first couple
Okay,
questions that
great.
we've done.
Yeah.
Yep. Okay. Well, welcome.
Okay.
All right. So number 4, we have a soccer player hits his head during an indoor game and is admitted to observation to watch for head trauma. They were admitted on January the 21st at 8:12 p.m. There was a medically appropriate history and exam and low medical decision making. And then they were discharged on January 22nd at 8:15 a.m. and they spent 20 times on discharge time. So, what are we going to report for the admission and discharge? Okay. So, when we're looking at observation, then let's go look at the section for observation. And that's going to be included for hospital inpatient or observation care services. Okay. So our admission happened on a different date than the discharge. So we can bill those separately, right? So we can bill the admission separately and the discharge separately. If it was the same day, then we would use the discharge, or there's a section of codes for admission and discharge on the same date. Okay. So for the admission, January 21st, 8:12 p.m., with a low medical decision making, what code are we going to use for the first day? Okay. So Dawn says 99234. Be careful, Dawn, because that is admission and discharge on the same date of service. So we want to make sure that we're using the initial hospital inpatient or outpatient, or I'm sorry, hospital inpatient or observation care code, not the admission and discharge same day. Yep. So we're going to do 99221. So 99221 is going to be our initial hospital care. Okay. We know that we have to report the discharge separately. So we're going to rule out C as well. Right. And then let's go flip at 99238 and 99239. And which one of those should we bill for our date of discharge? Yep, the 99238, because it's only 20 minutes. Okay. Any questions on that one? Okay. Number 5, a new patient visits the internal medicine clinic today for diabetes, hypertension, arthritis, and a history of cardiac disease. The provider performs a medically appropriate history and exam. Blood pressure is high and all other state conditions are stable. The labs ordered are the HbA1c and a complete blood count. And the dosage for the blood pressure medication is reviewed and changed. And the patient will follow up in 3 months. I'm actually going to pull this down. I'm going to get it all reset. Okay. So for this one, are we new or established? Yep, we're new. Okay. So we're going to rule out A and B automatically. And then we have to decide between the 99203 and the 99204. So we have to decide between low and moderate overall MDM. This one does not level it for us. So we do have to do the hard work with this one. Okay. So the number and complexity of problems that are addressed. How many? We have 3. Nope. We have 3 total problems, right? The blood pressure is high. So that's going to be a chronic with an exacerbation, right? Okay. Our diabetes we know that's a chronic condition. Is that stable or is that exacerbated? Stable. Yep. And then our hypertension. No, just kidding. We've already done hypertension. My bad. That's this one. We have arthritis. Okay. So with our arthritis, that's chronic, right? Is that stable or exacerbated? Stable. Yeah. Okay. So if we have 3 total problems, Two are stable chronic. One is chronic with an exacerbation. What level of number and complexity of problems do we have? Yeah, we've got moderate. Okay. Any questions on the number and complexity of problems? Okay. So the amount and complexity of data. So what have we done test-wise? Did we review any tests? Did we review any tests? Not order yet. We're just looking at review. Did we review anything? Right. And then we ordered how many? Okay. Yep, the HbA1c and the CPC. Okay. Did we review any prior notes for each for any sources? We did not. We didn't review anything from a prior visit prior to the encounter. Okay.
Because there's a new patient, correct?
Yeah, because it's a new patient. Now, they could have gotten prior notes from their previous physician and reviewed them, but we didn't. They did not indicate that they reviewed prior notes. Yep. Okay. Did we have an independent historian? Did we independently review any interpretations? Or sorry, did we independently interpret any tests? No. And then we did not have discussion of management or test interpretation. So if we reviewed, I'm sorry, not reviewed, if we ordered two new tests, what is our level for the amount and complexity of data?
Would it be moderate?
Nope. Remember, moderate, you have to have three. So in order to use a moderate amount and complexity of data, you have to have 3 points from category 1. And then Ramaya, you have to use high, you have to meet 2 requirements from category 1 or category 2 or category 3.
So what would be minimum?
Nope, it's going to be limited.
Limited.
So minimal is 1.
And
Moderate, I'm sorry, minimal is 1, limited is 2, moderate is 3.
Okay. I have the sheet here, but it's so teeny. I'm trying to figure out how I can blow it up.
I know. MDM is really, really crazy. So I do have a MDM. Let me see if I do have it pulled up. I do have a MDM table that I can put in the Google Drive that kind of help lay this out a little bit better. Let me show it to you guys here real quick.
I think this is the same one I'm looking at. I printed out some of the material. That's why I was trying to contact you earlier to see if what we were going to be doing tonight.
Yeah. So I have this here. It's literally the exact same information that's on page 9 and 10 in your CPT book. This is just kind of formatted a little bit differently that helps it make a little bit more sense. So this is telling you here that for the amount and complexity of data, you have 1 category 1 or less. Limited, you have 2 category 1s or an independent historian. Moderate, you have 3 category 1s or an independent historian, 1 category 2 or 1 category 3. And then extensive, you have to meet, it's the same criteria. You just have to meet 2 of the 3 versus the 1. So I'll get this
Oh,
posted in the Google Drive so that if you guys want to use this, now you can't take it into the exam,
right.
but you can use it for just like personal, studying and work related things. Okay. So
Hey,
we do
Tiffany,
have, yeah, go ahead.
can you please go back to the chart and just kind of walk us through how to think about it,
Yeah,
like you were
let's finish. Yeah,
already doing?
yeah,
Okay.
okay. So let me do this. I'm going to try to share them both at the same time, as long as my computer will cooperate. Let me do this. And then I want to share. Can you all see both of the screens now? It probably makes it a little small, but can you all see both of the screens now? Okay. So for the table B, which is your second column, the amount and complexity of data, okay, we did not review any prior external notes. We did not review the results of a unique test, but we ordered 2 new ones, right? So we've got 2 points here. We did not do an independent historian. We did not have the independent interpretation of any test. And then we did not have discussion of management. So now we only have 2 category 1s that we have met. So that's where we get our limited MDM.
Can you say one example for review of results of each unique test?
The results of each unique test, that would be if they went to the ER and they had an x-ray done. And whenever they go in to follow up with their physician, then they review the results of the radiology report.
Okay.
Or they had blood work done at the ER and the physician is looking at, in the office, they are looking at the results of the blood.
Thank you.
That would be the result of each unique test. Yep. Okay. Does everybody know what an independent historian is? Does anybody want me to go over what an independent historian is? Because I know that one, some people get tripped up on that one a little bit. Okay. Okay, so you want me to review. So independent historian is someone that has to come to the doctor's office with you and help corroborate the story. Now, that does not mean I'm going to go to the doctor with my husband and just give detail that he just doesn't want to give. Or I just want to be there because I don't trust him to come back and tell me what the doctor said, right? An independent historian is going to be someone that has to, like I said, help corroborate. So you're going to take your young child to the doctor and tell them they've been running 102 fever. They haven't, drank for 3 days. They vomited this many times, whatever. You take a 3-year-old to the doctor, they're going to say, my tummy hurts. And then that's all they're going to be able to really say, right? So that's going to be your independent historian. It can also be for an older child that might have an intellectual disability, or it could be for someone that you are a caregiver. It doesn't necessarily have to be in your family, but just a caregiver in general. If your grandparents have Alzheimer's and you go to the doctor and you have to basically say, this is what's been going on, that type of thing, that's going to be your independent historian. So somebody that is having to help give the history of the condition or the reason for the encounter. Okay, does that make sense? Now, another thing that people get caught up on is the difference between reviewing the results of a test and the independent interpretation of a test. So the difference between those are the category 1 review of the results of each unique test is, like I said earlier, you go to the ER, then you go to your doctor, and then you just kind of talk about, the results of the tests that were done. Okay. The independent interpretation of the test, that is going to be where if they have an X-ray or a CT scan or an MRI, and you go to your physician and your physician pulls up the images and interprets the images themselves. They're not looking at the radiology report. They're not looking at what the doctor said was wrong with them, anything like that. They are actually looking at the images and formulating their professional opinion about what those scans and images are showing. Okay, so that's the difference between the review of the results of a test and independent interpretation. Okay. So let me do this. Let's get back to this part. The labs ordered for your CBC and your HbA1c, and then the risk of complications. So our risk of complications, what do we think our leveling is going to be for the risk of complications and morbidity or mortality? Okay. Yep. Prescription drug management, because we had the dosage of our blood pressure medication is reviewed and changed. So that's going to be our moderate. And that's going to be a moderate risk of complications. Okay. So now we have moderate, limited, and moderate. What is our overall MDM? And then what code are we going to choose between 99203 and 99204? Yep. Overall, we have a moderate MDM. And then we're going to use 99204. Okay. So we're at the hour, which is crazy how quick it went. But do you guys have any questions about E&M? Just quick general questions about E&M? Okay. So here's the plan. We will not meet for the next 2 weeks. And that's just because it's Christmas Eve and New Year's Eve. And I think everybody kind of needs a little bit of a break. I know my brain does. I know my body does. But we will pick up again. Let me look at the calendar here. So we will not meet. No, sorry. Next week is Christmas Day. The week after is New Year's Day. So we will meet again on the 8th. So we will meet again in 3 weeks. Okay. So we will start completely over and do ICD-10. We'll start with chapters 1 through 5 of ICD-10-CM. And then we'll just kind of like do the whole thing from beginning and do all of that. I will start using the 2025 code set because that's what is going to be showing up on the exam as of January. So we will start using the 2025 code sets. You don't have to purchase 2025 books to participate in these study sessions for 2025. You can still use 2024. You can just write the changes into the books as we kind of encounter them, and things along those lines. And then, like I said, we'll just kind of restart all over again, and then do chapters 1 through 5 for ICD-10-CM, starting on January the 7th. Okay. Any questions? Any thoughts?
Okay,
Hey,
so for
Tiffany.
myself, I'm sorry. Go ahead.
No, go ahead.
Course or whatever. And so we use the AMA, just trying to get the 2025 to start over first
Sorry,
because I'm like so behind.
your audio completely cut out, and I just heard like the last like 2 seconds. Can
So
you
I
start
was
that over again? No, you're fine.
no
You're fine.
problem. So, I took the course through a community college, but she like kind of slowballed us, so we didn't really get all the knowledge we needed. And like, it's not like I'm a spring chicken or anything. I have much experience, but just by only really being certified from ICD 9 years ago to the 10 is a big conversion. So I'm
Yeah.
actually recommend like really to try to get the 2025 because I know you guys use the other edition. Whereas I'm using Optum.
Yeah, it's totally up to you. I mean, Optum is a good version of the ICD-10-CM. They all have the same like base material. They all have the same code set, code description, things like that. AAPC
Mm-hmm.
version is a really good version if you are in the learning phase. Whereas
Mm-hmm.
a lot of people will say that the Optum version of the ICD-10-CM is really for a little bit more geared towards like on the job type
Right.
things.
Mm-hmm.
So it's really up to you. There's not a requirement, anything along those lines. If you have the funds and you want to, make that purchase,
Mm-hmm.
then I mean, absolutely. Like, I mean, I love that version of the book.
Right, because
So it really just depends.
because I kind of find it a little bit difficult using the Optum compared to the AAPC trying to
Yeah,
follow along.
yeah, yeah. I haven't used Optum in years
Yeah,
just
because
because with me doing coaching and all of that, all of my students have the AAPC version.
right.
But I mean, yeah, if you want to make the switch to the AAPC version, I mean, it's not going to hurt anything.
Okay. And also I know you said you don't really recommend tabbing it. So once I get it, if I get it, don't bother tabbing it, just go ahead and start, Well, I'll probably have to start fresh, of course, with like doing the notations and everything and adding the notes.
Yeah, yeah. Tabbing is it's such a touchy subject. I know that there are some people that swear by it, and then
Mm-hmm.
there are some people that swear by not doing it. So really, it's kind of one of those things that just kind of see what it is that works best for you. If you want to use the tabs at first to learn
Mm-hmm.
the layout of the book and get comfortable with the book, then
Mm-hmm.
absolutely go ahead and use them. But once you start to realize that you know the layout, then go ahead and take those tabs off. So
Okay.
as long as they're not like a permanent version of the tab,
Mm-hmm.
then you can easily remove them whenever you get to the point where you feel like you're comfortable with them. So I don't ever want to tell anybody do not tab your book because
Mm-hmm.
I don't want anybody to because everybody learns differently, right?
Right.
But at the same time, in my experience and a lot of my students' experiences, if they do tab, then they take it off because they realize that the tabs eventually slow them down because they know the layout of the book strong enough.
Right. And so that's my
Yeah.
thing because I feel like I don't know the layout. And we did
Yeah.
it with this one, but again, as like it fell wayside, she spent so much time on the ICD 10 instead of the CPT. So when it came to
Hmm.
that, like, we kind of really just practiced and studied on our own.
Yeah.
So
Yeah.
it's like I
When
feel
I
like
was
I'm in the
when I was in
process.
school years and years and years ago, I had the exact same experience. Like my ICD-10 instructor, like she was great. And then my CPT instructor never showed up to class. So I had to teach myself CPT as well. So trust me, I know that feeling.
And so my other
Yeah.
question is I probably should follow up with the AAPC because they gave us 2 tries. And so I
Okay.
haven't utilized them. And I know it's like up until I want to say June or July, but I'm going to call and
Yeah.
confirm because
Yeah. Yeah. Definitely confirm when the
I,
expiration of those vouchers are for sure.
yeah, because I thought I was going to be well beyond and take it, but trying to
Yeah.
practice test, I'm nowhere near what I thought I would be.
Yeah,
So,
yeah, no, for sure.
okay.
One thing too that a lot of people don't realize is they think they have to use both of those attempts within the first year.
Right.
But the way that AAPC has restructured their stuff is as long as you use one attempt in that first year, then you get a year from
Mm-hmm.
that first attempt if you have to try it again. So
Okay.
let's just throw out dates, right? Let's say you take the exam on February the 1st and you do
Mm-hmm.
not pass. Okay.
Right.
You have 1 year from February 1st to reuse your second voucher.
Oh, okay, great. So I'm just
Yeah.
gonna call and confirm. So
Yeah.
this gives me hope because I was just frantic and not being log in because even my son, he was just like, and I'm like, I have like, and I see some people saying the same thing. So I don't know where I
Mm-hmm.
went. Link let me in, but also I just noticed like I have a Mac, and so I have this little, I don't know what you want to call it, UBS thing, and it seems like
Mm-hmm.
it kicks me out whenever I use this. So I'm trying to figure out just like the best way to be able to join and not get kicked out because I got kicked out several times. So I didn't
Are
really.
you talking for the study group? Do you have the
Yeah.
Zoom application downloaded onto your
Yes.
desktop
Yeah.
and
And
it's still kicking you out?
it just kept telling me the ID was wrong, but then I went to another space within legacy coding and it said
Uh-huh.
join a little box and I joined from that way and
You
then
know
it
what it
stopped
is?
connected.
I think Legacy, and we need to double check all of the links because we did have a link on the first half. And
Mm-hmm.
then for something happened with that meeting ID and that link. And so we
Mm-hmm.
had to create a new one. So it may be wherever it was that you were clicking for the first one was the outdated link.
Mm-hmm.
So wherever it was that you got the link for what you're on right now, that
Mm-hmm.
is the current link.
Yeah, because it's definitely a different ID number.
Yeah. Yeah. So use this meeting number, this ID number for meetings in the future and not
Okay.
whatever the other one is. We need, if you remember where it is that you found the one that's expired, shoot me a message and let me know where it's at, like a screenshot, so that I can make sure that that gets updated. Because I thought we had updated them all, but it never fails. There's always that one.
I think it's basically because I signed up for it and I have it signed to my calendar, but it goes right
Hmm.
back to that original link. So
Okay.
maybe just like right there,
Yeah.
shoot you
Yeah.
and show you what I'm talking about. I'm
Yeah.
sorry,
Yeah.
guys, to
Just
take
let
up
me know.
your.
No, you're totally fine. You are totally fine. And then Jeannie, I think you had a question too, right?
Yeah, I was just wondering, can you take like a specialty course? Like I wanted to do the anesthesia and pain management.
Hmm.
Can I do that right away or do I have to wait?
No, you can do it as quickly as you want.
Okay, because
Yep.
I checked our job listings every day. Right now, my healthcare organization has like 52 coding jobs posted. Some
Sure.
of them are coding liaisons for the physicians and stuff like that, but there are
Hmm.
several like anesthesia and women's health. So I was wondering if I could do the anesthesia one like
Yeah.
right away.
Yeah. You
Okay.
absolutely can if you wanted to. Yep.
Okay, good. Thank you.
You're welcome. All right. Well, yes, ma'am.
Um, can you just explain your boot camp? I think I messaged you last night. Can you just explain like what exactly it is?
Yeah.
Because I
So
know
the boot,
texting
yeah.
is kind of hard.
Yeah, yeah. So the boot
Sorry.
camp
Thank
is
you.
no, you're totally fine. The boot camp it's an 8 hour day. Okay. So we just had one this past Saturday, but we have the on-demand version and then we've got another one. I think it's in January. I'll have to look at the dates. But the boot camp is 8 full hours basically of instruction. We go through everything from beginning to end and we just kind of do like a high level overview of almost every single topic that is found in both CPT and ICD-10. So it is a very comprehensive, very fast paced. So it's not something that we recommend for people that are still in a program learning it because it can be very overwhelming if you haven't gone all the way through the course type thing. But with the boot camp, are you wanting to do the on demand version or are you wanting to do like a live version that we have in 2025?
I'm not sure. I recently just got done with my course, so I'm just
Mhm.
prepping for my state exam right now.
Gotcha. Okay.
I already did my AAPC review exam and I passed that with an 85, and then now they just sent me over to do the three free
Like
prep
practice
exams.
exams.
Yeah, and
Mm.
I haven't done those yet because I wanted just to like study up some more.
Yeah. Yeah.
So I just was wondering, what do you recommend? And
The boot camp is good if you just need kind of that refresher.
okay,
Um,
yeah.
So I know you said that you did like a review class, and I don't know exactly what they include now in the review class. Um, so I can't really say for sure whether or not the boot camp is going to be very similar to what the review class is, because that's kind of like a newer thing that they've offered.
Mhm.
But hopefully that kind of answers your questions. Like I don't, I'm trying to think of how to. Let's just put it this way. So when we do boot camp, there are almost 400 slides of information that we go through. So it covers everything. We do like it's not super in depth on some scenarios, but like we do go in depth on whenever to build like cabbages. We cover guidelines as far as like modifiers and things along those lines. But it is more focused on CPT versus ICD-10. But it just kind of is like that high level overview of everything.
Okay. And then when I
Okay.
purchase it, I'll have access for it for like the next
Yes.
couple weeks. Okay.
Yeah, absolutely. Mhm.
Okay. Thank you
Yep.
so much. I
You're
appreciate it.
welcome. Absolutely. You're very welcome. I think I think I started to respond to your question. Did I send the
No,
response to it?
no, you did. It's just easier
Okay. Okay.
talking
No, you're
than
fine. I just wanted
texting.
to make sure I didn't think that I responded to something and then I
No, you
didn't.
did.
Okay. Because if that does not describe my life right now of thinking that I've done something and then didn't actually hit the send button, then yeah. Okay.
Thank you.
You're welcome. Absolutely. Any other questions that you guys can think of? Okay. Well, so like I said, we will be off for the next 2 weeks. We'll meet back again on January the 7th, start all over again on ICD-10. And then if I don't talk to you guys either in the groups or on Facebook or whatever, have a Merry Christmas, have good holidays, stay safe, stay warm, and I will chat with everybody soon.
You too. Have a great holiday, everyone.
Thank you.